Hello, guys. Welcome to another episode of the Human AI podcast. Today, we're going to talk about malabsorption, malnutrition, the GI system, some general information about the GI system, and we're going to continue talking about urine formation. Check one of our previous episodes. We talked about urine formation in that one too. I'm just going to cover a bit of different bits in this one. Okay, if you're not familiar about the structure of this podcast, I'm not a teacher, I'm a student. I ask questions to Grok, an AI, and Grok explains everything that Grok says, guys. Make sure you cross reference it. I hope you find this information enjoyable and valuable. Okay, Grok, let's get into it. Let's start with malabsorption and malnutrition.
All right, let's dive into this. Malabsorption is when the body can't properly absorb nutrients from the food you eat, which can happen in the small intestine due to various issues like celiac disease, Crohn's disease, or infections. This leads to malnutrition, where you're not getting enough essential nutrients like vitamins, minerals, or proteins to keep your body functioning well, even if you're eating enough calories. For example, someone with celiac disease might eat a balanced diet, but their damaged gut lining can't absorb nutrients like iron or vitamin B12, leading to deficiencies. Symptoms of malabsorption can include diarrhea, weight loss, fatigue, or bloating, while malnutrition might show up as weak muscles, poor immunity, or even cognitive issues over time. Want me to break down any specific causes or how this ties into the GI system next?
Well, I want to understand a bit the word mechanical means in malabsorption. Talk to me a bit about missing enzymes too, maybe lactase, for instance, or maybe a pancreatic enzyme for cystic fibrosis. Yeah.
Got it. Let's unpack the term mechanical and malabsorption and touch on missing enzymes. When we talk about mechanical issues in malabsorption, we're referring to physical or structural problems in the GI tract that disrupt the breakdown or absorption of food. Think of it like a conveyor belt malfunction. Something's physically stopping the process. For example, in conditions like short bowel syndrome, where part of the small intestine is missing or surgically removed, there's just not enough surface area to absorb nutrients properly. Or, in Crohn's disease, inflammation can cause scarring or narrowing, messing with the gut's ability to churn and move food effectively. Now, onto enzymes. Enzymes are crucial for chemically breaking down food into absorbable bits. If they're missing or deficient, you get malabsorption because the nutrients stay locked in forms your body can't use. Take lactase, for instance, the enzyme that breaks down lactose, the sugar in milk. If you're lactose intolerant, your body doesn't produce enough lactase.
I
So
see.
lactase.
Just reminder, I always remind Grok, guys. Remember, answer in the least amount of words, but do it in such a way where your point gets across. So use use your words efficiently and effectively, Grog. And do this for the whole podcast, for the next 500 messages. Having said that, let me ask you about a few different things. Maybe we have an inadequate absorptive surface. Maybe we have maldigestion. Maybe it's bile salt deficiency. What types of disease do we have in each of these cases?
Got it. I'll keep it tight and clear. Inadequate absorptive surface means less intestine to soak up nutrients. Think short bowel syndrome or celiac disease, where villi are damaged. Maldigestion is when food isn't broken down properly, like in pancreatic insufficiency, cystic fibrosis, or lactase deficiency, lactose intolerance. Bile salt deficiency messes with fat absorption, often due to liver disease, cirrhosis, or bile duct issues, cholestasis. Each screws up nutrient uptake differently. Want specifics on any disease?
Um,
All right, so we were
yeah,
just
I
talking.
want to understand these a bit more, and also lymphatic obstruction, vascular disease, mucosal disease. It seems all of these they can produce some kind of specific disease.
Cool, let's break it down efficiently. Inadequate absorptive surface, like in short bowel syndrome or celiac disease, reduces nutrient uptake due to less or damaged intestinal lining. Maldigestion, seen in cystic fibrosis, pancreatic enzyme shortage, or lactose intolerance, missing lactase, means food isn't broken down for absorption. Bile salt deficiency, often from cirrhosis or cholestasis, impairs fat absorption. Lymphatic obstruction, like in intestinal lymphangiectasia, blocks lymph flow, causing protein and fat loss. Vascular disease, such as mesenteric ischemia, starves the gut of blood, harming absorption. Mucosal disease, think Crohn's or celiac, damages the gut lining, disrupting nutrient uptake. Each leads to specific nutrient deficiencies or symptoms. Want me to zoom in on one?
Yeah, mucosal disease and lymphatic obstruction. Actually, I would like to know.
All right, mucosal disease involves damage to the gut lining, like in Crohn's disease or celiac disease, where inflammation or autoimmune attack flattens villi, slashing nutrient absorption and causing diarrhea or weight loss. Lymphatic obstruction, like intestinal lymphangiectasia, blocks lymph vessels, leaking proteins and fats into the gut, leading to swelling, low protein levels, and fat malabsorption. Both mess with nutrient uptake but hit different systems. Mucosal wrecks the gut wall, lymphatic clogs the drainage. Need more on either?
Okay, let's talk a bit. Can you give us a case study now? Tell us, make something up, and we'll try to understand, what kind of nutritional problems this person might have.
Sure thing. Meet Sarah, a 28-year-old with undiagnosed celiac disease. She's got chronic diarrhea, bloating, and lost 10 pounds despite eating plenty. Her small intestine's mucosal lining is trashed from gluten, flattening villi and slashing nutrient absorption. She's deficient in iron, causing fatigue, and vitamin D, risking weak bones. Her body's not soaking up fats properly, leading to greasy stools. This mucosal damage screams malabsorption, and without a gluten-free diet, she's headed for worse malabsorption. Want me to dig into her treatment options?
No, dude, I want you to give us a case study and not let us know what this is, and I have to guess the nutritional problems.
My bad. Let's try that again. Meet Alex, a 35-year-old who's been dealing with persistent swelling in his legs, diarrhea, and unexpected weight loss for months. He feels weak, and his stools look pale and greasy. He's eating normally, but keeps dropping pounds. His blood tests show low protein levels, and he's got trouble absorbing fats. What's causing his nutritional issues? Go ahead and guess the condition and problems. Need a hint?
Tell me one more time.
All right. Alex is 35 with leg swelling, diarrhea, and weight loss. His stools are pale, greasy, and he's weak. Despite eating enough, he's losing weight, has low blood protein, and struggles to absorb fats. Guess the condition and nutritional problems. Want a clue?
Cystic fibrosis.
Good guess, but let's unpack it. Alex's symptoms: leg swelling, greasy diarrhea, weight loss, low protein, and fat malabsorption don't fully align with cystic fibrosis, which typically involves pancreatic insufficiency, causing enzyme shortages, leading to fat and vitamin malabsorption.
Vascular disease.
Nice try, but vascular disease, like mesenteric ischemia, usually causes abdominal pain, bloody stools, or acute gut damage. Not quite Alex's chronic leg swelling, greasy diarrhea, and low protein. His symptoms: weight loss, pale greasy stools, and fat malabsorption point more toward lymphatic obstruction, like intestinal lymphangiectasia. This condition blocks lymph flow, leaking proteins and fats, causing edema, low blood protein, and malabsorption from poor fat and nutrient absorption.
Okay, let's talk a bit about energy balance and then energy imbalance. So,
All right, let's switch gears. Energy balance is when the calories you take in from food match what you burn through basic body functions, activity, and digestion, keeping your weight stable. Energy imbalance happens when this is off. Too many calories in versus out leads to weight gain, often as fat. Too few calories in versus out causes weight loss, pulling from fat or muscle. For example, consistently overeating by 500 calories daily can pack on pounds, while undereating, like in starvation or malabsorption, burns reserves, leading to weakness or organ issues. Want me to connect this to malnutrition or specific GI conditions?
I want to ask you about IL-2, interleukin 4 and 6, and TNF alpha. These things, how do they affect energy balance?
All right, let's dive into how IL-2, IL-4, IL-6, and TNF alpha mess with energy balance. These cytokines, part of the immune system, can tilt the calorie in versus out equation. IL-2, often high in autoimmune diseases, ramps up immune cell activity, boosting metabolism and burning more energy, which can lead to weight loss if unchecked. IL-4, more anti-inflammatory, can indirectly support energy storage by calming immune overdrive, but its role is less direct. IL-6, elevated in chronic inflammation like Crohn's or cancer, spikes metabolism and breaks down muscle for energy, causing weight loss and fatigue. TNF-alpha, a big player in diseases like rheumatoid arthritis, also cranks up energy expenditure and suppresses appetite, driving weight loss and malnutrition in extreme cases, like cachexia. All these can disrupt energy balance by burning more calories or reducing intake, often leading to unintended weight loss and chronic illness. Want me to tie this to a specific GI disease or condition?
That's all good. Okay. Why don't we talk a bit about the GI system now? I mean, if you haven't noticed, we've been talking about the GI system for quite a while now, guys. But I think it's good if we continue towards this rabbit hole. So we've done a lot of kind of introduction to different parts of the GI system. Why don't we focus a bit from the top parts? So oral cavity, pharynx, and we'll go slowly more inferior in the body.
Cool. Let's start at the top of the GI system and work down. The oral cavity, where digestion begins, uses teeth to mechanically break down food and saliva, with enzymes like amylase to start carbohydrate digestion. The pharynx, a shared pathway for food and air, funnels chewed food into the esophagus via the epiglottis, which prevents choking. Swallowing is a coordinated reflex here. Want me to move to the esophagus next or zoom in on anything?
What's the cricoid cartilage?
The cricoid cartilage is a ring-shaped structure in the larynx, right below the thyroid cartilage, at the top of the trachea. In the context of the GI system, it's near the pharynx and esophagus, helping anchor muscles that control swallowing and keep the airway open during eating. It doesn't directly affect digestion, but supports the structures involved in moving food past the airway safely.
What about hiatus hernia and lower esophageal sphincter? Do we break this down to intrinsic and extrinsic?
All right, let's tackle hiatal hernia and the lower esophageal sphincter, LES. A hiatal hernia happens when part of the stomach slips through the diaphragm's esophageal hiatus into the chest, often causing acid reflux or heartburn. The LES at the bottom of the esophagus is a muscular ring that relaxes to let food into the stomach and tightens to prevent acid backflow. It's not formally split into intrinsic and extrinsic components, but you can think of its function as influenced by intrinsic factors like smooth muscle tone and local nerves, and extrinsic factors like diaphragm pressure or hormones. In hiatal hernia, the LES can weaken or misalign, worsening reflux. Want me to clarify the hernia types or LES mechanics further?
Can you explain this a bit more?
Sure. Let's break it down further. A hiatal hernia occurs when the stomach bulges up through the esophageal hiatus, the opening in the diaphragm where the esophagus passes. There are two main types: sliding, where the stomach and lower esophageal sphincter, LES, slide into the chest, and paraesophageal, where part of the stomach squeezes beside the esophagus. Both can cause reflux, pain, or trouble swallowing. The LES is a band of smooth muscle at the esophagus-stomach junction. Its intrinsic control comes from muscle fibers and the enteric nervous system, which regulate its tone to open for food and close to block acid. Extrinsic factors include the diaphragm's pressure, which reinforces the LES, and hormones like gastrin, which tightens it, or progesterone, which can relax it like in pregnancy. In hiatal hernia, the LES often loses diaphragm support or alignment, making it less effective, leading to reflux. Want more on symptoms, causes, or how this affects digestion?
That's good. Let's go to the stomach now. So tell us about the cardinal notch. And let's also talk about the fundus, the angular incisure, the pyloric canal, the pyloric. Explain us how the names relate to the location too.
All right, let's dive into the stomach, focusing on the cardiac notch, fundus, angular incisure, pyloric canal, and pylorus, tying their names to their locations. The cardiac notch is the sharp angle where the esophagus meets the stomach at the cardia, just below the diaphragm. Its name comes from its proximity to the heart, sitting right under it, and it's where the lower esophageal sphincter operates to prevent reflux. The fundus is the dome-shaped upper part of the stomach, above the level of the esophageal opening. Its name, from Latin per bottom, is a bit misleading. It's actually the topmost part, filled with gas in an upright person, stretching upward toward the left diaphragm. The angular incisure, or incisura angularis, is a notch or bend on the lesser curvature, the stomach's inner curve, and marks the transition from the body to the lower part of the stomach, named for its sharp, angular shape, roughly dividing the stomach into upper and lower regions. The pyloric canal is the narrow, tubular passage leading to the pylorus. It's in the stomach's lowest part, near the exit, and its name reflects its channel-like structure, funneling food toward the pylorus. The pylorus is the stomach's gateway to the small intestine, a muscular ring with the pyloric sphincter controlling food release into the duodenum. Its name, from Greek for gatekeeper, nails its location and role at the stomach's distal end, right before the small intestine. Each name reflects either the structure's shape or its position relative to the stomach's layout, from the heart-adjacent cardia to the gatekeeping pylorus. Want me to go deeper into stomach functions or move to the small intestine?
I would like to understand the gastric canal, the gastric fold, and the pyloric sphincter a bit more. I mean, I kind of get pyloric sphincter, but what's the point of the other two?
All right, let's zoom in on the gastric canal, gastric folds, and clarify the pyloric sphincter's role, focusing on their purpose in the stomach. The gastric canal, also called the gastric groove or Magenstrasse, is a temporary, functional pathway along the lesser curvature from the esophagus to the pylorus. It forms when the stomach contracts, channeling liquids like water or saliva quickly toward the pylorus for rapid passage to the small intestine, bypassing heavy mixing. Its point is efficiency, speeding up liquid emptying without needing the full grinding process. Gastric folds, or rugae, are the thick, wrinkled inner linings of the stomach, especially prominent when it's empty. They're made of mucosa and submucosa, stretching out as the stomach fills. Their purpose is twofold. They expand the stomach's capacity, like accordion folds, and increase surface area for secreting acid, enzymes, and mucus, aiding digestion and protecting the stomach lining. The pyloric sphincter, as you mentioned, is the muscular valve at the stomach's exit, controlling the flow of partially digested food, chyme, into the duodenum. It stays mostly closed, opening just enough to release small amounts of chyme at a time, ensuring the small intestine isn't overwhelmed and digestion is paced. Together, the canal speeds liquid transit, folds enhance digestion and capacity, and the sphincter regulates outflow. Want specifics on how these work in digestion or move elsewhere in the GI tract?
Okay. How does the name intraperitoneal relate with the stomach? And also tell me a bit about the hepatogastric and gastrosplenic ligaments. What's the point of those? And the hepatoduodenal ligaments too.
All right, let's tackle how intraperitoneal relates to the stomach and break down the hepatogastric, gastrosplenic, and hepatoduodenal ligaments, focusing on their purpose. The term intraperitoneal means the stomach is fully surrounded by the peritoneal membrane and suspended within the peritoneal cavity, unlike retroperitoneal organs, like the pancreas, that sit behind it. This gives the stomach mobility to expand, contract, and churn food, with its position stabilized by ligaments. The hepatogastric ligament is a thin peritoneal fold connecting the lesser curvature of the stomach to the liver. It's part of the lesser omentum, and its point is to anchor the stomach to the liver while carrying blood vessels and nerves, helping maintain the stomach's alignment during digestion. The gastrosplenic ligament links the greater curvature of the stomach to the spleen, also a peritoneal fold, stabilizing the stomach's left side and carrying short gastric arteries to supply blood. It keeps the spleen and stomach in relative position, preventing excessive twisting. The hepatoduodenal ligament, another part of the lesser omentum, connects the liver to the duodenum, not directly the stomach, but relevant to the GI setup. It encases the portal triad, hepatic artery, portal vein, and bile duct, delivering blood and bile for digestion, while anchoring the duodenum near the liver. These ligaments collectively tether the stomach and nearby organs, ensuring they stay put during digestion while allowing enough movement for function. Want more on peritoneal anatomy or how these affect stomach mechanics?
Yeah. How come the hepatogastric and the hepatoduodenal ligaments make the lesser omentum? This makes no sense to me.
Fair question. Let's clear it up. The lesser omentum is a double-layered peritoneal fold that connects the stomach and duodenum to the liver. It's made up of two parts, the hepatogastric ligament and the hepatoduodenal ligament. The hepatogastric ligament runs from the lesser curvature of the stomach to the liver, while the hepatoduodenal ligament extends from the duodenum to the liver. Together, they form one continuous structure, the lesser omentum, because they both originate from the same peritoneal sheet during embryonic development. Think of it like a single curtain hanging between the liver and the stomach duodenum combo, split into two named sections based on what they connect. Their job is to stabilize these organs and carry key structures like blood vessels, nerves, and a bile duct in the hepatoduodenal part. It seems confusing because they have different names, but they're just two segments of the same peritoneal sling. Want me to explain the embryology behind it or move to another GI topic?
That's so good. So, let's talk a bit about the small intestine then. So, it begins at the pyloric orifice. Why?
All right, let's jump to the small intestine. The small intestine begins at the pyloric orifice because that's the exit point of the stomach, where the pyloric sphincter controls the release of partially digested food, chyme, into the duodenum, the first part of the small intestine. The pyloric orifice is like a gatekeeper, strategically placed at the stomach's lowest point to ensure chyme is already processed enough by stomach acid and enzymes before entering the small intestine for further digestion and nutrient absorption.
And what does orifice mean?
An orifice is just a fancy term for an opening or passage in the body. In the case of the pyloric orifice, it's the specific opening where the stomach, at the pylorus, connects to the small intestine, duodenum, guarded by the pyloric sphincter to regulate the flow of chyme.
Okay. So, tell me about plicae circularis, villi and microvilli, how they differ. 2 sentences.
Plicae circularis are permanent circular folds in the small intestine's inner lining, increasing surface area for absorption. Villi are finger-like projections on these folds, covered in microvilli, tiny hair-like structures, further amplifying surface area and housing enzymes for nutrient breakdown.
Okay. What's going on in the jejunum and the ileum? Do we also have plicae circularis? And compare me the lumen and the wall's thickness compared to other parts of the intestines. Talk to me about the vasa recta too. Arcades, what are arcades? And yeah.
All right, let's dive into the small intestine's anatomy, focusing on vasa recta and arcades. The vasa recta are straight, slender blood vessels branching off the mesenteric arteries, running directly to the small intestine's walls to supply blood to the jejunum and ileum. Their name, meaning straight vessels in Latin, reflects their linear path, ensuring efficient oxygen and nutrient delivery for absorption. Arcades, on the other hand, are looping networks of blood vessels formed by branches of the superior mesenteric artery in the mesentery. These vascular arches, hence the name arcades, connect multiple arterial branches, creating a web that supplies the intestine and allows collateral blood flow, so if one vessel is blocked, others can still perfuse the gut. Plicae circularis, villi, and microvilli, which we touched on earlier, maximize surface area for nutrient absorption, while vasa recta and arcades ensure the blood supply to make it all work. Want me to clarify how these vessels support digestion?
No, that was a great answer. Okay. I want to ask about Peyer's patches, aggregated lymphoid nodules' function, and explain to me how it relates to their name and structure.
All right, let's talk Peyer's patches. Peyer's patches are aggregated lymphoid nodules, clusters of immune tissue in the mucosa of the small intestine, mostly in the ileum. Their function is to monitor and fight pathogens in the gut, housing immune cells like B and T lymphocytes that detect bacteria or viruses in food or mucus, triggering immune responses like antibody production. Named after Johann Conrad Peyer, who described them in the 17th century, their patchy, oval-shaped structure reflects their scattered, raised appearance on the intestinal lining, designed to maximize exposure to gut contents for immune surveillance. Want me to connect this to gut immunity or move on?
No, that was a good answer. Okay. Tell me about the duodenum. Is it retroperitoneal and why? Does it have a connection with the hepatoduodenal ligament? Talk to me about how the mesentery relates to the small intestine.
All right, let's break down the duodenum and its connections. The duodenum, the first part of the small intestine, is mostly retroperitoneal, meaning it sits behind the peritonei cavity, fixed to the abdominal wall, except for its initial short segment, the duodenal cap, which is intraperitoneal. This retroperitoneal setup, due to its embryonic fusion with the posterior abdominal wall, stabilizes it for receiving chyme and bile, though it limits its mobility compared to the genuum or ileum. Yes, it connects to the hepatoduodenal ligament, part of the lesser omentum, which links the duodenum's first part to the liver, carrying the portal triad, hepatic artery, portal vein, bile duct to support digestion. The mesentery, a peritoneal fold, doesn't directly anchor the duodenum, since it's largely retroperitoneal, but it suspends the jejunum and ileum.
Fucking hell, dude, you have butchered completely the word retroperitoneal and intraperitoneal. Anyway. Okay.
My bad. Let's get those terms straight and pick up where we left off.
No. Let's talk about the appendix. I want you to explain to me the Taenia coli and the blind intestinal diverticulum, and explain to me prelial, postileal, subcecal, although that makes kind of sense.
All right, let's dive into the appendix, Taenia coli, and those positional terms. The appendix is a blind intestinal diverticulum, a small tube-like pouch off the cecum, the start of the large intestine, with no clear digestive function, but it contains immune tissue and can trap bacteria, hence its name as a blind-ended outpouching. The Taenia coli are 3 longitudinal muscle bands running along the colon, not directly on the appendix, but nearby, converging at its base. Their name, from Latin for ribbon, reflects their flat, tape-like structure, guiding colon contractions. The appendix's position varies: ileal, behind the ileum; postealial, further back from the ileum; or subcecal, below the cecum, with these names describing its location relative to the ileum or cecum, affecting surgical approaches if inflamed. Want more on appendicitis or the colon's anatomy?
No, this is great. Okay. Let's talk about the rectosigmoidal junction, and let's talk about the anorectal flexure. What's that? The ampulla of the rectum? Yeah, that's about it, really.
All right, let's cover the rectosigmoidal junction, anorectal flexure, and ampulla of the rectum. The rectosigmoidal junction is the transition point where the sigmoid colon, with its S-shaped curve, narrows and straightens into the rectum, marked by a shift from the mobile intraperiantine sigmoid to the fixed retroperidiantine rectum, aiding the shift from stool storage to controlled passage. The anorectal flexure is the sharp angle where the rectum bends forward at the level of the sacrum and coccyx, created by the puborectalis muscles' sling-like action. It helps maintain continence by kinking the rectum to hold stool until voluntary relaxation during defecation. The ampulla of the rectum is the dilated lower part of the rectum, just above the anal canal, acting as a temporary reservoir for feces before expulsion, with its name, Latin for flask, reflecting its widened, bulbous shape. Want to dig into rectal function or move elsewhere?
So the intraperitoneal, retroperitoneal, and subperitoneal, is the intra most superior and subperitoneal most inferior?
All right, let's clarify intraperienti, retroperienti, and subperitoneal and address their relative positions. Intraperienti organs, like the stomach or most of the small intestine, are fully wrapped in the perientine membrane, hanging freely in the abdominal cavity with mobility. Retroperienti organs, like the kidneys or most of the duodenum, lie behind the periantium, fixed to the abdominal wall with less mobility. Subperitoneum refers to structures below the periantine cavity, like parts of the bladder or rectum in the pelvic cavity, not covered by periantinium on their lower surfaces. Superiority or inferiority doesn't strictly apply here. It's not a vertical hierarchy. Instead, intraperienti organs are generally more central and mobile in the abdominal cavity. Retroperienti ones are posterior against the back wall.
Okay.
And
So let's talk a bit more about the pectinate line, and perhaps let's also talk about the anorectal junction again and the anocutaneous white line, because I'm a bit confused.
all right, let's clear up the pectinate line, anorectal junction, and anocutaneous white line. The pectinate line in the anal canal marks the transition between the upper visceral mucosa from endoderm, less sensitive, with venous drainage to the portal system, and the lower somatic mucosa from ectoderm, pain sensitive, draining to systemic veins. It's a jagged, comb-like boundary, hence pectinate, where anal glands and crypts sit, crucial for distinguishing hemorrhoid types. The anorectal junction, slightly higher, is where the rectum turns into the anal canal at the anorectal flexure, formed by the puborectalis muscles sling, creating a sharp angle for continence control. The anocutaneous white line, or Hilton's line, is lower, at the anal verge, a pale ring of skin where the anal mucosa meets external skin, marking a visible boundary, named for its whitish appearance and guiding surgical landmarks. The confusion often comes from their proximity. The anorectal junction is about continence. The pectinate line divides tissue types, and the white line is an external marker. Want me to sketch out their clinical relevance, like in hemorrhoids or surgery?
No, that's so good. Why don't we talk about fecal continence, the ampulla, the internal anal sphincter, and the external one, their differences, tonic contraction, puborectalis. Yeah. And a bit more about the anorectal flexure. Put it in a nice system for us to understand.
All right, let's organize fecal continence, focusing on the ampulla, internal anal sphincter, external anal sphincter, puborectalis, and anorectal flexure in a clear system. First, fecal continence is the ability to hold stool until voluntary defecation, relying on coordinated structures. The ampulla of the rectum, the dilated lower rectum, acts as a reservoir, storing feces temporarily. Its wide, flask-like shape, hence the name, allows it to expand and signal the urge to defecate via stretch receptors. Next, the internal anal sphincter, a ring of smooth muscle in the anal canal, maintains tonic contraction, constant low-level squeeze involuntarily, controlled by the autonomic nervous system. It's the first barrier, keeping the canal closed at rest to prevent leakage. The external anal sphincter, a striated muscle surrounding the internal sphincter, is under voluntary control via the somatic nervous system. It provides extra closure during sudden pressure, like coughing, or when delaying defecation, capable of strong, conscious contraction, unlike the internal's automatic tone. The puborectalis muscle, a sling-like part of the pelvic floor, loops around the rectum at the anorectal junction, creating the anorectal flexure, a sharp 90-degree angle between the rectum and anal canal. Its tonic contraction pulls the rectum forward, tightening the flexure to maintain continence by kinking the passage, like pinching a hose. During defecation, it relaxes to straighten the angle. The anorectal flexure, formed by the puborectalis, is key to this system, as its angle enhances closure pressure. It works with both sphincters, the internal sphincter's steady grip, the external's on-demand boost, and the ampulla's storage, all coordinated by nerve signals to balance continence and defecation. In short, ampulla stores, internal sphincter auto-clamps, external sphincter manually reinforces, puborectalis kinks via the anorectal flexure. Want me to dive into disorders like incontinence or how these work during defecation?
This is great. Well, why don't we talk a bit about blood supply? Tell us about the celiac trunk and about arteries in general. So, left gastric artery, splenic artery, gastroepiploic artery, gastroduodenal, gastric artery, hepatic artery, probehepatic artery, common hepatic artery. Let's try to understand these all together. Maybe starting from the big ones and how they branch off to the smaller ones. That would be a good idea.
All right.
Let's do it.
Okay. Cool. Let's break down the celiac trunk and its related arteries. Left gastric, splenic, gastroepiploic, gastroduodenal, gastric, hepatic, proper hepatic, and common hepatic in a clear system, starting with the big ones and how they branch. The celiac trunk is a major artery off the abdominal aorta, just below the diaphragm, supplying the foregut, stomach, liver, spleen, and part of the duodenum. It splits into three main branches: the left gastric artery, splenic artery, and common hepatic artery. The left gastric artery runs along the lesser curvature of the stomach, supplying its upper part and part of the esophagus with smaller gastric branches, sometimes just called gastric arteries. The splenic artery, the largest branch, heads to the spleen, but also feeds the stomach via short gastric arteries and the left gastroepiploic artery, which supplies the greater curvature. The common hepatic artery leads to the liver but gives off key branches: the gastroduodenal artery, which supplies the stomach's pylorus and proximal duodenum, and the right gastric artery, which joins the left gastric along the lesser curvature. The gastroduodenal also feeds the right gastroepiploic artery, supplying the greater curvature alongside its left counterpart. After these branches, the common hepatic becomes the hepatic artery proper, sometimes just hepatic artery, splitting into right and left branches to supply the liver. In short, celiac trunk splits into left gastric, stomach, splenic, spleen, stomach via gastroepiploic, and common hepatic, liver via hepatic artery proper, plus stomach duodenum via gastroduodenal and gastroepiploic. This web ensures the stomach and nearby organs get robust blood flow. Want me to clarify any branches?
Great answer. Okay, let's talk a bit about the ileocholic artery, right cholic artery, middle cholic artery, and superior mesenteric artery. Now, do the same thing, same kind of system.
All right, let's dive into the superior mesenteric artery, SMA, and its branches: ileocholic artery, right cholic artery, and middle cholic artery, using the same clear system, starting with the big one and tracing the branches. The SMA, a major artery off the abdominal aorta, just below the celiac trunk, supplies the midgut, lower duodenum, jejunum, ileum, cecum, ascending colon, and proximal two-thirds of the transverse colon. It gives off several key branches. The ileocholic artery, one of the first branches, heads to the terminal ileum, cecum, and lower ascending colon, also supplying the appendix via its appendicular artery. Its name reflects its dual role in the ileum and colon. The right cholic artery, branching off next, supplies the ascending colon, running toward the hepatic flexure, named for its focus on the right side of the colon. The middle cholic artery, typically the highest branch, supplies the transverse colon, from the hepatic to the splenic flexure, its name indicating its central role in the colon's middle section. These arteries form arcades and vasa recta, like we discussed earlier, creating a network to ensure robust blood flow to the intestines. In short, SMA branches into ileocholic artery, right cholic, ascending colon, and middle cholic, ascending colon, and middle cholic, transverse colon, each targeting specific midgut regions. Want me to tie this to digestion or move to another vascular
Well,
topic?
no, but I do want to ask you about the marginal artery, and I want you to tell me about watershed area and anastomosis and collateral supply.
All right, let's dive into the marginal artery, watershed area, anastomosis, and collateral supply, keeping it clear and concise. The marginal artery, also called the marginal artery of Drummond, is a continuous chain of arterial branches running parallel to the colon, formed by connections between the ileocholic, right cholic, middle cholic, and left cholic arteries from the superior and inferior mesenteric arteries. It acts as a highway, distributing blood along the colon's length, especially critical for the ascending, transverse, and descending colon. Anastomosis refers to the connections between these arteries, where their branches link up to form the marginal artery, creating a network that allows blood to flow between different arterial territories. This setup provides collateral supply, alternative blood flow routes, so if one artery is blocked, say the middle colic, the marginal artery can still perfuse the colon via other branches. The watershed area is a vulnerable zone, typically near the splenic flexure, Griffith's point, or rectosigmoid junction, Sudeck's point, where the superior and inferior mesenteric arteries territories meet. These spots rely heavily on the marginal artery's anastomosis and have weaker collateral supply, making them prone to ischemia if blood flow drops.
Okay,
In
I
short,
would like to know a bit more about this anastomosis, but having said that, I would also like you to explain to us a bit more about the veins. So, hepatic portal vein, splenic vein, superior mesenteric vein, inferior mesenteric vein.
all right, let's dive into anastomosis in the context of the marginal artery and then unpack the hepatic portal vein, splenic vein, superior mesenteric vein, and inferior mesenteric vein, keeping it clear and concise. First, anastomosis refers to connections between blood vessels, allowing blood to flow between different arterial or venous territories. In the colon, the marginal artery is a prime example, formed by anastomotic links between branches of the ileocholic, right cholic, middle cholic, and left cholic arteries. These connections create a continuous arterial chain along the colon, ensuring blood can reroute if one artery is blocked, providing collateral flow to prevent ischemia, especially in watershed areas like the splenic flexure. Now, onto the veins. The hepatic portal vein is the main vein collecting nutrient-rich blood from the GI tract, stomach, intestines, spleen, and delivering it to the liver for processing before it enters systemic circulation. It's formed by the convergence of the splenic vein and superior mesenteric vein, with the inferior mesenteric vein typically joining one of these. The splenic vein drains the spleen, parts of the stomach via short gastric and left gastroepiloic veins, and pancreas, running behind the pancreas to merge with the superior mesenteric vein. The superior mesenteric vein drains the small intestine, jejunum, ileum, cecum, ascending colon, and most of the transverse colon, collecting blood from areas supplied by the superior mesenteric artery. The inferior mesenteric vein drains the descending colon, sigmoid colon, and upper rectum.
All good.
Usually
All good. And a few sentences I want to know about superior rectal artery and how it connects to the rest of the arteries we talked about. Same with the middle and inferior rectal artery.
The superior rectal artery, a branch of the inferior mesenteric artery, supplies the upper rectum and sigmoid colon, connecting to the marginal artery via anastomoses with the left colic artery, ensuring collateral flow to the colon. The middle rectal artery, from the internal iliac artery, feeds the mid-rectum, with weak anastomoses to the superior rectal artery. The inferior rectal artery, from the internal pudendal artery, supplies the lower rectum and anus, linking minimally with the middle rectal artery, but not significantly with the marginal artery system.
Okay, and tell me, how does the lymphatic drainage work? I want you to mention the thoracic duct in your answer, the cisterna chyli, the intestinal trunk, the right and left lumbar trunks.
All right, let's break down lymphatic drainage in the GI system, incorporating the thoracic duct, cisterna chyli, intestinal trunk, and right and left lumbar trunks. Lymphatic drainage starts with lymph capillaries in the intestinal villi, called lacteals, which absorb fats and lymph from the gut. These drain into lymphatic vessels that follow the arteries, like the superior and inferior mesenteric, to regional lymph nodes, e.g., mesenteric or celiac nodes, filtering pathogens and cancer cells. The intestinate trunk, a major lymphatic channel, collects lymph from the stomach, intestines, pancreas, and spleen, typically draining into the cisterna chyli, a sac-like structure at the base of the thoracic duct, located near the L1, L2 vertebrae. The cisterna chyli also receives lymph from the right and left lumbar trunks, which drain the lower limbs, pelvis, and abdominal walls. The thoracic duct, the body's main lymphatic highway, begins at the cisterna chyli, ascends through the thorax, and empties lymph into the venous system at the junction of the left subclavian and internal jugular veins. In short, gut lymph flows via lacteals to the intestinal trunk, joins lumbar trunks at the cisterna chyli, and travels through the thoracic duct to return to the bloodstream. Want me to zoom in on a specific part or clinical issues like lymphedema?
This is great. I want to ask a bit about autonomic innervation now too. If you could mention the vagus nerve, the greater, lesser, and least splanchic nerves, pelvic splanchic, the lumbar splanchic, and if you could also mention in your lesson hidden gut, mid gut, foregut, that would be great. And parasympathetic, sympathetic, differentiate between.
All right, let's tackle autonomic innervation of the GI system, covering the vagus nerve, greater, lesser, and least splanchic nerves, pelvic and lumbar splanchic nerves, and tying in foregut, midgut, hindgut, while distinguishing sympathetic and parasympathetic roles. The autonomic nervous system regulates GI functions like motility and secretion via parasympathetic, rest and digest, promoting digestion, and sympathetic, fight or flight, slowing digestion inputs. For the foregut, esophagus, stomach, duodenum, liver, pancreas, the vagus nerve provides parasympathetic innervation, stimulating motility and secretions. It runs from the brainstem, sending fibers via celiac and superior mesenteric plexuses. Sympathetic innervation comes from the greater splanchnic nerves, T5, T9, which synapse in the celiac plexus, inhibiting motility and constricting blood vessels. The midgut, lower duodenum, jejunum, ileum, cecum, ascending transverse colon, also gets parasympathetic input from the vagus nerve via the superior mesenteric plexus, boosting peristalsis. Sympathetic input here is from the lesser splanchnic nerves, T10, T11, synapsing in the superior mesenteric plexus, slowing gut activity. The hindgut, descending, sigmoid colon, rectum, receives parasympathetic innervation from the pelvic splanchnic nerves, S2, S4, promoting motility and defecation via the inferior hypogastric plexus. Sympathetic innervation comes from the lumbar splanchnic nerves, L1, L2, and least splanchnic nerve, T12, via the inferior mesenteric and hypogastric plexuses.
Explain to me prevertebral celiac and aortic plexus then.
All right, let's break down the vertebral, celiac, and aortic plexuses in the context of GI autonomic innervation, keeping it concise. The vertebral plexus isn't a standard term for GI innervation, but likely refers to autonomic nerve networks around the vertebral column, like the sympathetic chain ganglia near the vertebrae, which feed into splanchnic nerves, e.g., greater, lesser, least, for sympathetic input to the gut, inhibiting motility and secretions. The celiac plexus, a dense nerve network around the celiac trunk, is a major hub for the foregut, stomach, duodenum, liver, pancreas. It receives parasympathetic fibers from the vagus nerve to boost digestion, and sympathetic fibers from the greater splanchnic nerves, T5, T9, to slow it, relaying signals to organs via smaller plexuses. The aortic plexus, broadly referring to nerve networks along the abdominal aorta, includes extensions like the superior mesenteric for midgut and inferior mesenteric plexuses for hindgut, integrating vagal, parasympathetic, and lumbar splanchnic sympathetic inputs to regulate intestinal motility and blood flow.
I
In
see.
short,